All right, well, it's 7:30, so we're going to go ahead and get started. Welcome to Geriatric Grand Rounds, everybody. It's actually the last Grand Rounds of this academic year, so thanks to everyone for joining in. Few announcements before we get to today's presentation. Like I said, this is the last for the year, so we'll pick up again in September and keep you informed as we get closer to that, what that's going to look like in terms of being in person versus virtual options as we get that guidance clarified from the university. Also, I would just say, as we look to start putting the schedule together for next academic year, if you have an interest in presenting or if you have suggestions for topics or speakers, please feel free to send those on to me. Those are always appreciated. Our next journal club will be May 13th, and our presenters will be Jason Hayes and Andrea Stan, so please join us for that. Following Grand Rounds today, you will receive an email with a link to the presentation and a copy of the PowerPoint. Will also be a link to an online evaluation, so if you could please take a moment to fill that out and send it back, it's greatly appreciated. During the presentation, feel free to submit questions in the Q&A or chat box at any time, and we will save time for those, getting to those questions at the end of Dr. Mullen's presentation. So I am pleased to announce our speaker for today, Dr. Rebecca Mullen. She's an assistant professor at the CU Department of Family Medicine. She practices broad spectrum family medicine in both the outpatient and inpatient settings and is an educator in the family medicine residency program. Her research interests include loneliness and social isolation, aging health disparities, and LGBTQ plus health. She's going to talk to us today about loneliness and social isolation in primary care with a closer look at the aging population. So thank you so much, Dr. Mullen.
Yes, thank you. Thank you all for having me. I'm so happy to be here. As mentioned, today we'll be focusing on loneliness and social isolation, and specifically with a refined lens and focusing on implications to primary care and obviously implications to the aging population, given we're talking at Geriatric Grand Rounds. This is a research topic and a clinical topic that is a personal passion interest of mine. And there's just too much to possibly tell you all in 45 to 50 minutes, but I've done my best to kind of summarize the general overview of what we know in the literature and what people are currently working on. So hopefully this is helpful and interesting. By the end of the talk, I'm hoping that you all will feel comfortable describing and defining loneliness and social isolation, diagnosing and identifying them, and also describing what their health impacts are. I also hope that you'll understand the prevalence, the high prevalence of loneliness and social isolation, and particularly as that pertains to the aging population. And also we'll be discussing examples of interventions in primary care settings and just the general overarching approach of what the primary care role might be in addressing loneliness and social isolation. And of course, I'll be sure to mention COVID during this talk. I would be remiss if I didn't address the pandemic that's been going on for the past year and a half when talking about loneliness and social isolation. So I will be sure to address that as well. Before I get started, I just want to give special recognition and acknowledgement to this resource that was made available for free online last year. It was actually funded, sponsored by AARP in addition to some other national entities, and was put forth by the National Academies of Science, Engineering, and Medicine. And it is a wonderful resource that basically is an overarching summary of everything that I'm going to say today. I used a lot of their information for my topic, and it does really specifically focus on older adults and opportunities within the healthcare system. So highly recommend downloading this, having it on your computer, particularly if you're interested in this topic from a clinical or research perspective. So before we get going any further, it's really important to make sure we're all on the same page about definitions and terminology. And you may have noticed over the past year and a half that people are talking more and more about loneliness and social isolation during COVID. And that's appropriate. That's great that they are. But it can get really confusing because people inappropriately interchange these two terms and use loneliness and social isolation as if they are the same thing, when really they're two discrete constructs, two different factors of social relationships. And it's important to really acknowledge that before we can understand how we might identify them and what we might do about them. So loneliness is really an internal sensation. It's a self-perceived gap between the social connections that you have and that which you aspire to have. It has been called perceived social isolation, so further confusing why we might mix it up with objective social isolation. But this is really something that you internally feel. It is not the same as being shy or introverted, and it's also technically not the same as being depressed or anxious, because the focus is really on that the feeling of discrepancy in regards to your social relationships. And this is in comparison to social isolation, which is something that's outwardly obvious to everyone. It's an objective state of being physically separate. This marked having few social contacts or few network ties. And what I'll make sure to note here before we move on as well are some terms about social relationships that we're not going to be talking about today that are also really important and also have their own place in this literature. Things like social support or social inclusion, social cohesion, social vulnerability. Those are all also really important constructs within the realm of social relationships. But for the purpose of the talk today, we're going to be focusing on loneliness and social isolation, which are two functions of social disconnection, loneliness being more of a functional domain and social isolation being more of a structural domain of social disconnection. If you're more of a picture person, here's how you might imagine loneliness versus social isolation. You can imagine that term, you can feel alone in a crowded room, and that's loneliness. It's a sensation inside of you that no matter how many people you're physically surrounded by, you might just not have the relationship quality or quantity that you desire. Versus social isolation, as I mentioned, is outwardly obvious. It is an objective state of being separate from others. So why does this matter? Well, I figure if I told you, do you want to know the secret for living a longer, healthier life? You would almost certainly say, well, yes, of course, Beka, I definitely would like to know that secret. And I'll tell you, I know it, and many people know it, and this has been actually established time and time again over the past 30 to 40 years in research studies. And that's the importance of social connections and social relationships with our health. And they're actually strongly linked to health and longevity. And in fact, by a study published by Dr. Julianne Holt-Lundstadt, who you'll see is referenced throughout this, this presentation, is really a seminal researcher in social connections. She has cited that social connections are associated with a 50% increased odds of survival. So incredibly important to our overall health and well-being. The opposite is also true. Loneliness and social isolation as two domains of social disconnection are associated with negative physical and mental health outcomes. So let's talk more about this before we move on, because I think this is really helpful in understanding why loneliness and social isolation have negative health impacts on us. And so we as humans, our human nature is to be connected. We are a social species. Our survival actually depends on our collective ability and not our individual mind. And this is despite our culture really thriving as an individualistic or supporting an individualistic nature. As humans, we're actually quite interdependent, and you can see that throughout our lifetime. From infancy, we rely on others. In adulthood, we survive by banding together. You can think of hunters, gatherers, there's safety in numbers. And then again, as we age, we rely on the care and support that others provide us. And this is known to be particularly imperative in tough times, where humans lean in on each other to get by during times of crises. And I don't have time today to talk to you about the seminal research studies that really support this with evidence, but this has been illustrated quite elegantly in some of our research. So if human connections are a survival mechanism, then loneliness and social isolation are a threat to that survival. And when we are separated from our tribe, either objectively or in a perceived way, our body goes into a physiologic stress state. That stress state is supposed to be our impetus to go reconnect. It's supposed to be a survival mechanism, just like our other survival drives like hunger and thirst. Therefore, you can imagine the pathophysiology of isolation, how loneliness and social isolation contribute to poor health. It's through a variety of established, plausible biologic mechanisms that explain the negative effects of social disconnection on our health. That includes increased vascular resistance, adrenocortical release, blood pressure, poor sleep, plus or minus health behaviors. But this increased stress response, this drive that happens when we are separated from our tribe. This is a figure that Dr. Holt-Lundstadt and Smith put together to illustrate this in a slightly different way of how you might take from social connection or disconnection all the way to morbidity and mortality, and how the different, the possible mechanisms by which social connection may influence disease. And that includes, as I mentioned, lifestyle and health behavior. This also includes certain psychological measures such as stress, resilience, purpose. And it includes actually medication adherence and compliance, because there's a growing amount of literature and data to support and illustrate that when people feel socially connected, they're more adherent to what we tell them that they should do for their health. And the opposite is true. When they're more socially disconnected, they are less adherent. You could imagine all three of those, how they could then plausibly lead to increased inflammatory markers, increased blood pressure, and other biomarkers that would lead to increased morbidity and mortality. So the most compelling evidence on the impact of loneliness and social isolation on our health is definitely on all-cause premature mortality. And there actually have been a whole host of studies, large meta-analyses that support this. And I don't have time to go into those in detail, but what I will tell you that I think is really important for us, particularly in clinical care or in research, those that are taking care of patients or family members or loved ones or neighbors, is that this magnitude of effect of loneliness and social isolation on mortality is comparable to or even greater than other well-established risk factors that we're talking about, thinking about, educating patients about all the time, that are getting a ton of press, a ton of attention, and yet loneliness and isolation are right up there, if not even greater risk factors to mortality. And that includes smoking, obesity, physical inactivity. I mean, how much attention do those risk factors get in regards to talking to people about, how important it is to quit smoking, for example? We actually have really compelling evidence to suggest social isolation specifically has an impact on mortality that may even be greater than that of smoking. And this is independent of age or initial health status. To really hone this in, hopefully I'm getting my point across, but loneliness, social isolation, and living alone exceed the risk of death associated with obesity, physical activity, and air pollution. So again, risk factors that we commonly think of, that we commonly cite, that we know to be bad for our health. These factors, these social disconnection factors, are thought to be even more deadly than what we're already talking about and what's already getting a lot of attention. This is from one of Dr. Holt-Lundstadt's manuscripts in 2017, and is just another way to illustrate the importance of social connection on our mortality. And you can see here at the top that, let me see if my marker works. At the top with the black bars are measures of social connections, in comparison to the gray bars are measures of our leading health indicators. And these are comparisons of odds of decreased mortality. So you can see at the top, two different measures of social connection and integration are actually shown and known to have higher odds of decreased mortality than other readily accepted indicators for for improving health, such as smoking cessation, alcohol cessation, flu vaccine, physical activity, etc. So really, really important for our mortality. You might also then imagine that loneliness and social isolation increase the risk of developing certain health conditions that will therefore also impact and play into the all-cause mortality. And this is not meant to be an exhaustive list by any stretch of the imagination, but I did want to specifically pull out comorbidities that I thought would be particularly pertinent to the geriatric and aging population. So loneliness and social isolation, both independently, have been shown to increase the risk of stroke and coronary heart disease, and that's independent of cardiovascular risk factors, hypertension, depression, anxiety, and even dementia. And this was actually in a 2015 meta-analysis. Loneliness and infrequent social contacts was shown to increase the risk of dementia by about 50%, which was comparable to other well-established dementia risk factors, such as type 2 diabetes and low physical activity. So really important risks here. Loneliness and social isolation are also associated with other comorbidities that are really important in our aging populations, like diabetes, insomnia, suicidality, functional loss, such as decreased ADLs and mobility, and decreased quality of life. So if you needed another tagline, one final tagline to convince you, this is something that's at this point probably really been oversighted and overused. But I think is still a really powerful statement that prolonged isolation has been cited as being as detrimental as smoking 15 cigarettes per day. So hopefully I've set forth a convincing argument that this is really important for the health of our patients. There are also health system outcomes to loneliness and social isolation that are associated with the increased use of the healthcare system. That includes hospital readmissions, emergency room visits, PCP visits. It also includes early reentry to residential or nursing care facilities, prolonged use of SNFs, and increased Medicare spending. So outcomes that I think are really important when thinking about our geriatric and aging populations. Another reason that it's really important to think about this in the aging populations is that our older adults are at a high risk to develop loneliness and social isolation. And that's because they encounter age-related changes in their health and in their social connections that then are known to be precipitants and risk factors for loneliness and social connection. So here are a list of known established risk factors for loneliness and social connection that our aging population are at really high risk for. That includes living alone, retirement and unemployment, loss of family or friends, chronic illness and poor health, sensory impairments, mobility impairments, memory impairments, and lack of transportation. And that's just a list of few. But you could imagine, compiling all these together, that older adults become a really high risk population that we really need to have our spidey senses up about if they have loneliness or social isolation. So let's pivot a little bit to talk about the prevalence of loneliness and social isolation. And I'll start by saying the prevalence is really difficult to quantify and report because unfortunately in the clinical settings and research settings in which people have been looking at loneliness and social isolation, we still don't have one standard measurement tool that we're using. In fact, there's a whole host of different measurement tools that people are still using to this day. So that makes it really hard to quantify, one standard prevalence or one accepted prevalence. And you would imagine with added complexities of looking at different demographics, different age groups, different geography areas, et cetera, it just makes prevalence pretty hard to know for sure. But I can tell you with confidence there are some accepted trends. That includes social isolation peaks in older populations. And that makes sense, right? Because older populations are more likely, as I just mentioned in the last slide, to live alone or to have loss of a loved one or loss of a significant relationship that they've been living with, or to have transportation issues that then further isolate themselves. Loneliness, on the other hand, although about 10, 15 years ago, was previously thought to be an aging quote unquote disease is actually now over the past 5 years or so, pretty well accepted to be the most prevalent in younger populations. This again is not always consistent in every single study, but there have been some big major studies over the past 5-10 years that have illustrated, yes, older populations have a high prevalence of loneliness, but wow, the Gen Z and millennials, they have even more loneliness than our aging populations do. And so this, I think really illustrates that we need attention on both ends of our age spectrum here. There is some evidence to suggest, as you might imagine, that these both have increased during COVID. And unfortunately, as I'll get to a little bit later, this is less clean cut, less clear cut than you would hope or imagine. But there, logically, you might imagine how loneliness and social isolation have both increased during COVID. So here are some numbers, I just preface this with prevalence is really hard to tell you, really hard to, officially make a claim on, but here are some numbers that are really commonly cited that I feel very comfortable giving you that you can go back to and reference later on that are based on very large nationally representative studies in regards to thinking about the prevalence of loneliness and social isolation. So for social isolation, specifically for older adults, there was a great study a couple of years ago pre-COVID that illustrated about a quarter of our community dwelling adults, 65 or older, were socially isolated. So a significantly high prevalence. Loneliness is less clear. You will see prevalence reports all over the map. But one of the most highly studied prevalence studies was the AARP study that was originally published in 2018, where they surveyed over 6,000 adults above the age of 45. And that found that over 1 in 3 adults over the age of 45 were lonely. That study found that the highest prevalence of loneliness was in the age range of 45 to 49, where almost half were lonely, in comparison to the lowest prevalence being 70 and above, where a quarter were lonely. Again, still a very high prevalence. You may also see using the quotes of 40% of older adults being lonely. There are a couple, again, large nationally representative studies that have found similar numbers, including the health and retirement study that I've referenced for you there. And I just want to mention the Cigna study that was also published in 2018, which was not specifically focused on older adults, but was huge. They surveyed over 20,000 people. And they found, this was actually one of the studies that really opened up the conversation for saying, you know what, loneliness is actually more prevalent right now in our younger populations, still very prevalent in older populations, but our Gen Z and millennials in particular are actually citing a higher prevalence than our older populations. So those are some numbers to go back and refer to, but hopefully you can see that this is incredibly prevalent. I was able to lead a study a couple of years ago that specifically looked at the prevalence of loneliness in our primary care patients. And we surveyed over 1,200 adults presenting to primary care clinics in Colorado and Virginia. And we found that 1 in 5 adult patients walking into our primary care clinic for any reason whatsoever, whether that was an acute sick visit or a preventive care visit, 1 in 5 were lonely, so incredibly common. We also found that loneliness decreased with age. So we found a similar trend to the Cigna study. Having said that, I would still argue, 11% prevalence of loneliness in those above the age of 65, 1 in 10, that's still incredibly common. And by some statistics, by some reports, that's more common than many of the disease states that we think to be significantly burdening our primary care settings, or our primary care patients, including diabetes, depression, anxiety, heart disease. So, it's really common and really important that we start more strategically thinking about in primary care. So how do we think about it in primary care? How do we recognize loneliness and social isolation? Well, I think it's important to mention that your patients might not name it outright, and patients might not present classically, quote unquote, whatever that might mean. There's a lot of stigma around being lonely or being isolated. And I think a lot of patients just don't have the vocabulary or the terminology to even know that that's what they're going through. So you often have to have a high suspicion and be looking for it and be aware of the type of person that would be at higher risk to know in what situation you should be looking for it and more aware. Loneliness in particular, very similar to depression and anxiety, can also be kind of like a great masquerader. It can present as a whole variety of different types of symptoms that are not just a patient saying, wow, I wish I had more friends. For older men in particular, again, similar to depression, it can look like irritability, anger, even aloofness, withdrawal. So you have to really be keen to looking for this. So my two messages for recognizing loneliness and social isolation big picture are A, think about this when you think your patients might be at high risk for any reason or another. Maybe that's a major life event or a major life transition. And B, think about using validated measurement tools that are brief and easy to administer, whether that's in a research setting or in a clinical setting, to use as your assessment and identification. So I wanted to give you some examples of the most common measurement tools that we're using, both clinically and in the research realm for loneliness and social isolation. Again, not meant to be an exhaustive list by any stretch of the imagination, but just to show you that well, first of all, this is to give you an illustration about why prevalence is so hard to quantify because there are so many different measurement tools, but also just to give you an example of there are some really easy kind of short tools that can be easy to deliver, whether that's in a clinical or a research setting. The UCLA loneliness scale and the Jong Gierveld loneliness scale are two of the most popular loneliness measurement tools, both originally developed in the 80s and now have both been modified, revised, and abbreviated. And I will show you those two momentarily. Campaign to End Loneliness Scale, really more of an honorable mention here. I like it. It's a 3-question scale that I think is actually quite good. I haven't really seen it in the literature, so I wouldn't necessarily support advocating, widespread adoption. But I think it's great to mention because the Campaign to End Loneliness did partner with patients age 50 and above to create that tool. So I really like the patient engagement perspective that they use to create that scale. And many people just use single item scales. Are you lonely? Social isolation, on the other hand, I'm just going to show you a couple, but the Berkman-Syme Social Network Index was one of the seminal indices of how to capture social isolation. May not be as relevant today. It was initially developed in '79, and some of the questions may not be as relevant, but it was adapted into the Lubben Social Network Scale, which is often used and has an abbreviated 6-item version that I will show you. And again, in italics on the side there, you'll note what I'm not going to show you. There's a whole variety of wonderful social support scales, social integration scales, social cohesion scales. Those are really wonderful, and many of them in a lot of ways overlap with loneliness or social isolation, but do not purposely only capture loneliness or only capture social isolation, so are really out of the realms of what we're talking about today. Here's the UCLA 3-item version. How often do you feel you lack companionship? How often do you feel left out? How often do you feel isolated from others? And then it's scored with a higher score indicating a greater degree of loneliness, but you actually can use cutoffs and dichotomize the score as well. This brief scale, I would say, is, in my opinion, from what I've seen, is the most widely used in research and in clinical settings for assessment of loneliness. The Jong Gierveld scale, though, is also very popular. This is the abbreviated 6-item version. And what it offers that the UCLA doesn't is the capability to look at different types of loneliness. So 3 questions ask specifically about social loneliness or missing a wider social network, versus the latter 3 questions ask about emotional loneliness or missing an intimate relationship. And you might imagine for a person, depending on the type of loneliness that's involved, that might have implications to next steps and interventions. And again, this is scaled with higher scores indicating a more loneliness, but this can actually also be dichotomized as well. Berkman-Syme Social Network Index, as I mentioned, was one of the seminal social isolation assessment tools. Asks about frequency of talking on the phone, how often you get together, frequency of getting together with your friends, attending church or religious services, and attending basically volunteer clubs or organizations. So I think this is really worth mentioning because, as you may know, the Institute of Medicine Committee report in 2014 was the first time that the IOM said social connections are so important that we actually need to be routinely asking about this in the clinical setting, and more importantly, documenting it in our EHRs. And in that committee report in 2014, they supported the adoption of this social network index, these 4 items. This is what they proposed would be in our EHRs. Now, again, how relevant, well, definitely how relevant is this today during COVID, but also, generally speaking, how relevant is it? I think that's up for argument. Most people, in my opinion, in comparison to the previous index, use the Lubben, social network scale, this is the revised 6-item version. And they did use the Berkman-Syme social network index and adapted it, but removed questions about religious activities and really focused more heavily on the quality and quantity of individual relationships with your families, your relatives, your friends. There are also a whole variety of other ways that people are capturing social isolation, but I wanted you to see 2 kind of brief assessment tools. Okay, so now let's pivot. I promised you I would weave in some discussions about COVID-19 and the impact to isolation. And I would be, absolutely remiss if I didn't address that. And I really do think it is important. We went into COVID-19 already in a loneliness and social isolation pandemic, and now we're in a COVID pandemic, hopefully soon to be, coming out of it. But we are, and this then was deemed the double pandemic, this isolation and COVID-19 pandemic. And how do these 2 interplay or play on each other, or do they? So there's ample reason to believe that the COVID-19 pandemic would worsen isolation. It's been an unprecedented landscape for social disconnection, whether it's government-sanctioned stay-at-home orders, so literally the government forcing people to isolate, or isolation and quarantine related to people's exposures or related to their immune status or their health concerns, and then add on complexities of the added responsibilities when they're spending more time away from others, they're working from home, they're juggling childcare. It just becomes a more complex environment. You could imagine how these all, in theory, could worsen both isolation and loneliness. And then throw in this social distancing, which really should have been called physical distancing, because social distancing kind of makes it seem like we want to socially disconnect. And that's actually not the purpose at all. It's just to physically distance ourselves, but try to find other ways to stay socially connected. But you could imagine with social distancing, people's social calendars suddenly cleared right on up. We had a lot of social activities suddenly canceled, and many people had difficulty maintaining their relationships or keeping up with their, social responsibilities. And then finally, these feelings of uncertainty, anxiety, and worry. You could imagine how all of these would compound and add on to loneliness and social isolation globally, but definitely in the US. And I think really important for our aging population is to mention this social connectivity paradox, where when we, during COVID-19, increase our level of social interaction, trying to mitigate our social isolation or trying to tackle our loneliness, we directly increase our COVID-19 risk. And this is really important, again, for those that are aging or those that are immunosuppressed. And so I think we've been having to kind of have this internal risks benefits conversation about how much risk we're comfortable with for a year and a half, and it's incredibly fatiguing and it's incredibly stressful. And I think many of the aging population have erred on the side of very low social interaction so that they can help decrease their health infection risk from COVID-19. However, there is another side to this story that I think helps explain why the data around what's happened with loneliness and social isolation to some degree during COVID is a little bit muddy and not quite clear across the board. As you may remember from the beginning of this talk, I talked about how our human nature is to be connected, and during times of crises, our human nature is to lean in on each other. And you might call COVID-19 one long crisis. And there has been an increased sense of a collective challenge, a sense of solidarity that we're all going through this together. We have this shared experience. Some people, and I recognize that this is not the case for all, but some people have actually enjoyed and thrived with their increased time at home with loved ones. I have some colleagues that have said, this is the most I've seen my teenage kids since they were babies. And it's been, absolutely wonderful. And that, recognizing that not all parents have felt that way. In fact, many parents have, dealt with the exact opposite, the stress of kids having to do virtual schooling and working from home at the same time. But that's not the case. That's not the story for everyone here. There's also been an immense amount of increased reliance, leaning in on our social networks, on our neighbors, on our family members. And instead of withdrawing, we've been reaching out to others more. We've increased the frequency that we reach out to people. And so you can imagine the positive impacts that would have on social isolation and loneliness. And then finally, there might be a flip side to that social distancing, where for some, there was actually a relief, a decrease in social pressure, a decrease in the FOMO or fear of missing out, where they said, the social calendar, yeah, it's clear, but man, I don't mind it. I've actually enjoyed it. So I just want to say that it's not fair to say that across the board, the story has been the same for everyone. And I think this explains why it's so hard to cohesively summarize what's happened with loneliness, specifically during the COVID pandemic. The other reason it's really hard to summarize, though, is because of the immense amount of research and publications that have come out over the past year. And I'm sure you all have felt this as well in your own areas of study, but absolutely the number of publications about mental health during the COVID-19 pandemic is mind-numbing. And the quality of publications and the quality of studies is not great. And so I found this article on Nature that I thought was fascinating, where per this source, as you can see here, charting from January 2020 to November 2020, the topic of manuscripts being published, initially, by far, most manuscripts focused on COVID, the diagnosis, the testing, the treatment, the outcomes, etc. But as the year went on, if you follow that light blue line, more and more publications focused on mental health during COVID. And we have just seen an overwhelming amount of literature, a plethora of cross-sectional survey studies that have made it really, honestly, quite difficult to know exactly what the story is, because many studies are contradicting each other. One will say, loneliness is booming, and the next will say, actually, we haven't found that loneliness has increased at all. So I think, honestly, part of that is just this immense amount of low quality data. And when the dust settles in 6 months, 9 months, 12 months, that's when I think we'll actually have a true appreciation of what has happened with loneliness and social isolation during COVID. But I am going to do my best to summarize to the best of my capability, just from an overarching view about what I can tell of what's happened. And the first thing to note is just, mental health clearly is suffering, no doubt about it. Anxiety, emotional distress and stress, depression have all absolutely increased during COVID. And this is disproportionately experienced by younger adults, racial, ethnic minorities, essential workers, and unpaid caregivers. There's also been quite a few studies to illustrate that suicidal ideation has increased during this time as well. But as I've alluded to, the data really is conflicting about what's happened during loneliness. And from one cross-sectional survey to another, one might say loneliness has increased a whole bunch, and the next might say, actually, we didn't find that that is the case at all. So my statement to you is, I think it probably depends. Probably depends on the demographics that are surveyed and how the questions are being asked about loneliness. And as I mentioned before, for some people, this really has been a time of increased reliance and increased connecting with others, versus others that maybe are younger, living alone, single. Those might have been at higher risk demographics that I think when the dust settles, we'll probably see that those were the demographics that suffered the most from a loneliness perspective. So if I were to give this talk again in a year, I think I would have a much better, much more cohesive story for you. Objective isolation has increased, and that's very logical, I think, with stay-at-home orders, as I mentioned, with quarantining, with social distancing. And this is particularly in the older populations as they're trying to isolate themselves from COVID risk. I did find a recent publication that in the UK that illustrated the average daily number of contacts was reduced by about 74%. So I think, no doubt about it, objective isolation has increased during this time. So let's pivot back a little bit to reorient about ourselves about what might be our role in addressing this in the primary care setting. So we've already kind of talked about how important it is to acknowledge the existence and importance of loneliness and social isolation. We've learned how to identify loneliness and social isolation in our practices, in our research world, in our lives. Now let's talk about, is there any role for intervention, and particularly as it pertains to primary care? So my first statement is, I do actually think primary care may be the ideal setting to intervene on loneliness and social isolation. And I know that can be a gut-wrenching statement because primary care, including geriatrics, is already incredibly overburdened and spread very, very thin. But hear me out. There's a couple of reasons why I think that there's reason to believe this. The first is that we have really high level of contact with our patients that are really at risk for this and really suffering. And so we are touching these patients all the time and seeing them all the time. The second is that in primary care, it's becoming increasingly feasible to address social determinants of health. And I don't mean to oversimplify this. I know it's incredibly complex and screening is challenging, and there's lack of access to and lack of consensus on measures and ability to track and monitor them in EHRs, and evidence on interventions for social determinants of health is messy and complex. So I don't mean to oversimplify that, but what I do mean to say is this is a movement that's happening that has a ton of attention from policymakers to payers to entire healthcare systems, as people really recognize, wow, our patients' social circumstances are having a huge impact on their health. And we would save a whole lot of money if we do figure out how to address it. So loneliness and isolation should absolutely be a part of that conversation and ride that train. I mean, it's a movement that's happening, and I think we belong and deserve to be a part of that as well. So within the primary care setting, should you do universal screening? Should you do targeted assessment? Kind of what is the thought process on that? And what I will say is that it's really pretty well accepted that we're not at a point that we should be doing universal screening for loneliness or social isolation. However, there are reasons to suppose that screening might be in our future because A, the very high prevalence of these issues, and B, the very severe health consequences. But we don't have a national gold standard for how to address or intervene or mitigate these issues. And we don't understand the unintentional health consequences of universal screening. So we are not there yet, but I do wonder 10, 15 years down the road if we might be similar to where we are now with like a PHQ-2. So currently as it stands, really think about doing targeted individual assessments. So using those measurement tools that we reviewed for your higher risk patients, maybe it's a patient that brought up with you specific concerns, but otherwise using your intuition to tell you, wow, this is a patient that's single, that's living alone, that just lost a major relationship, that just went through a geographic move, that was just given a significant, burdensome health diagnosis, that has had a recent decrease in functioning. For any of these reasons, I feel like they're at increased risk for loneliness and social connection. And so I might want to do some targeted assessment. And so what are our implications for our primary care clinical practice? Once you've identified loneliness and social isolation, the first thing to do is to attempt to determine any low-hanging fruit underlying causes. And that's because particularly in the aging population, there really are some underlying etiologies that have very clear evidence-based interventions. For example, as I've mentioned, not to keep repeating myself, but like hearing issues, that is a significant risk factor for loneliness and social isolation, mobility issues, transportation issues. So having a conversation with the patient and saying, based on this measurement tool, it does look like you're lonely, and opening up that conversation about how does that resonate with you, and what do you think about loneliness, and what do you think may have been contributing to this, can be extremely helpful. And then obviously make sure to document in the EHR so you can monitor and track over time. From an intervention perspective, honestly, it's really less clear at this current time what works best and what works best for whom. So currently, what folks are saying is provide education, talk with your patients about the adverse health outcomes. If you've made this diagnosis, tell them, this is something I'm really worried about, I'm very concerned about, and it's actually quite deadly. So I'd like to work together with you to figure out how we can address this. But we don't necessarily at this point in time have a gold standard in what the intervention should be. And I'm going to speed up how quickly I'm talking so I can get through the rest. But I do want to let you know that there are 4 broad intervention types that are generally studied in the literature. But again, the evidence is not clear that any of these are superior for loneliness or social isolation than others. But just to let you know what people are generally looking at and focusing on. That includes increasing social access. So like a prescription to the YMCA or silver sneakers, or getting someone access to transportation. It also includes interventions that improve social support or foster or build new relationships, like befriending, mentoring, support groups. There are also a whole set of interventions that actually focus on social skills, with the thought that if patients don't feel that they have adequate socializing skills and techniques, that they're going to therefore become at very high risk to become lonely and isolated. And then there's finally a whole bucket of interventions that actually have less to do with social prescribing and more to do with the maladaptive cognitive processes that can come along with definitely loneliness and sometimes social isolation. But you could imagine for someone who's lonely, there actually can be a paradoxical vicious cycle where although they have the internal desire to increase their social connections, they might actually withdraw socially and have perceived negativity towards others. So interventions like CBT that challenge negative thought processes and negative thought patterns help lonely people reframe the way that they're thinking about their relationships or assumptions about others. And so that actually has a lot of promise and is getting a lot of attention specifically for the loneliness intervention realm. But just to hone in on that, we don't have a clear gold standard yet. There was a 2019 AHRQ evidence review that basically said, we don't know, that specifically focused on older adults, that in summary said, we don't really know what sort of strong claims we can make. We do think that the physical activity interventions, so the interventions that increase social access opportunities that are focused around physical activity, have a lot of promise. And we also think there's a lot of promise with interventions that are connecting isolated older adults to health services in the community. But again, basically said, we need better studies, we need more studies. COVID-19 has changed what we can offer patients and the types of interventions that we can even possibly study during this time. So I just want to mention that 2 types of interventions and approaches have really bubbled to the top during the pandemic as the most promising, the most feasible, the most readily available. And that includes the psychosocial CBT mindfulness approach, as many behavioral health folks have rapidly went to virtual health, and we're able to therefore continue being able to care for patients. The same can be said for those that were taking care of lonely and socially isolated patients from a psychological standpoint. So that has maintained as an opportunity for lonely and socially isolated people during the pandemic. The second opportunity of intervention that has really maintained is the remote outreach and befriending. So you can see from the JAMA psychiatry there, and I know something very similar was happening in the Department of Geriatrics, where most commonly we were seeing telephone calls to our older patients, our older populations, whether that was happening by a layperson or a student or a clinical worker, but just this outreach to people to stay connected with them, to make sure that they have the resources that they need. And that actually does have some promising results in regards to loneliness and social isolation. We lost access to many of the community programs that we were using, like physical activity, and those were no longer accessible to us. And there was a Cochrane review that illustrated that just shifting all of your activities to video conferencing isn't effective for reducing social isolation and loneliness for older people. So if you are interested in thinking about interventions for loneliness and social isolation during COVID, I would encourage you to really think about the CBT psychosocial approach in addition to these remote outreach approaches. Okay, so my last couple of slides. What else can you do? Just talking about these issues is so incredibly important and vital. Sharing resources as you hear of organizations that are addressing loneliness and social isolation, community-based programs, providing education to patients, colleagues, researchers. I think as awareness grows, certainly the quality of research studies will grow as well, and we'll just have better evidence to be able to really direct us. And eventually, hopefully 5-10 years from now, we will actually have gold standard interventions for loneliness and social isolation, which we so desperately need. And not to be too corny, I guess, but I just want to remind you that even small acts of social engagement can be really helpful to improve and increase connection with our patients or our loved ones in the moment. So in those patient encounters that feel hopeless, that feel really difficult and really challenging to address, there actually is evidence to show that even small actions like actively listening, sharing gratitude, really focusing on positive events that have happened in the patient's life can be really meaningful for that person and can increase their sense of connection. So even if you're not referring to some sort of big intervention program, small actions can make a big difference too in regards to loneliness and social isolation in that moment. And then the last thing, partner with researchers, maybe like me. If you're interested in addressing loneliness or social isolation from a research perspective or a clinical perspective, as I mentioned in the beginning, this is a huge passion of mine, and I would love to talk with you and collaborate with you and partner with you. So as a recap, we learned that loneliness and social isolation are deadly and are common, that the aging population is at a very high risk for both of these. And in the primary care role, we need to think about how we can better identify patients that are suffering from these two entities, how we can educate patients. And then we need to think more strategically about how we can leverage our position to intervene, and particularly as better evidence comes out about efficacious interventions. And then we also reviewed the COVID impacts, the multitude of COVID impacts on loneliness and social isolation. So I will leave you here with a quote. Dr. Vivek Murthy, you probably know, is the previous Surgeon General, and he has made it a point to really focus his work on loneliness and social isolation. Just came out with a book last year called Together, and he gives really wonderful talks about this, about how we all need to focus in every aspect of our lives of how we can be more connected with ourselves and with one another. And so he says, as we build connected lives, we make it possible to build a more connected world. So thank you so much. I will end it with that and with my baby Gus, and open it up to see if there are any questions.
Thank you, Beka. That was wonderful. Really great topic and presentation, so thanks. Have a couple of questions / comments. So first of all, Dr. Lum, with respect to the interventions specifically around telephone outreach and befriending, just says great shout out to Coast It, which was our outreach through the seniors clinic, and also to Gierveld for groups of veterans. So that was one comment there. And then another question also from Dr. Lum is, what is known about social isolation as a dementia risk factor, perhaps from the health and retirement study?
Yes, so social isolation and loneliness are both, I think dementia plays in both ways. Dementia is known to be a risk factor for social isolation and loneliness, and social isolation and loneliness are known to be risk factors for developing dementia and cognitive impairment. So actually the relationship goes both ways. The strongest data that I've seen, actually, let me see if I can go all the way back, was I believe quoted by Dr. Julianne Holt-Lundstad, where she said that the risk of dementia itself with social isolation and loneliness was increased by 50%. So if someone is socially isolated or lonely, and specifically in this study, what they looked at was loneliness and infrequent social contacts. That's how they captured social isolation. And they found that the risk of dementia increased by 50%, which, as I mentioned earlier, was comparable to other dementia risk factors, such as physical inactivity, type 2 diabetes, late life depression, etc. But it is a complex relationship that goes both ways, and I think is ample for further research.
Great, thank you. So another comment from Dr. Farrow in our behavioral health in the seniors clinic. Loneliness and isolation have been the primary topic in behavioral health interventions at the seniors clinic this past year, especially, but was common even before COVID. And one resource that she has used is the covia.org Well Connected program. So everyone should be able to see that in the chat box. Yeah, everyone should be able to see that link in the chat box. So thanks, Dr. Farrow.
That's great. Thank you for that. Yeah. I think it's so wonderful to be able to share resources like that, because we currently don't have, actually, I just saw Dr. Julianne Holt-Lundstad. I'm totally a groupie of hers. I don't know if you can tell, but I just saw her speak last week, actually. Actually, Dr. Lum sent me the invitation to her discussion, and she mentioned that there is going to be a clearinghouse for these types of resources, that they're, you know, by those researchers in the field that are really well established, that it is highly recognized that we need a better capability to track interventions and evidence and resources that are working really well, kind of similar to the Campaign to End Loneliness in the UK, but I think a little bit more evidence-based, evidence-driven approach, where the Campaign to End Loneliness has really just summarized what's been going on in the UK. And so she mentioned that there was a big movement to create a clearinghouse to share these types of resources and evidence.
And let's see, a couple more comments also from Dr. Farrow. She says also she has seen that one reason the pandemic is having mixed impacts is because it may be related to gaps in skills related to social connections and loneliness. And that such gaps are pre-existing to COVID, but were exacerbated by the past year's challenges. And I'm trying to put that resource that she mentioned into the Q&A box, because apparently people can't see it in the chat, and I'm having a hard time pasting it in there. So I will try to figure that out.
Yeah, I think the interventions that focus on social skills are really, really fascinating. And I do think that there's some promise there. I do think that, you know, particularly in the day and age of technology and social media, and as more and more people are kind of ingrained in their phone, that I do think that there's a sense of loss of ability to just connect with others face to face, and that that problematic internet use that's been slowly increasing, and what's been the impact of our ability to socialize with others. So I do actually think that there's some promise there with in thinking about how can we improve our social skills.
And then another resource, Leah Haverhall says she's part of a social isolation and loneliness work group through the CDC that provides great weekly resources. She came to know about it through GSA, which has tons of great groups and resources on studying loneliness and social isolation among older adults. So GSA sounds like a good resource as well. Thank you for that. Any other questions or comments? We're at the end of the hour here. So we'll go ahead and wrap it up. Please look for the evaluation in your email and send me any suggestions or thoughts you have for next year's speaker lineup. And thank you all for attending Grand Rounds this year. And thank you so much, Dr. Mullen, for wrapping it up. And everyone have a good summer.